Few more students will be joining.
Thank you, sir. Thank you.
Wait, another 4-5 minutes. In my place, it's thunderstorms and raining heavily, lightning. I don't know whether the net will go. Okay. Where are you right now?
Chennai, sir. In Chennai.
Okay. The background, it's seeing seashore and all.
Yes, sir. I have created it for all practical purposes so that I can sit and start connecting with the class.
Okay, fine. It looks nice.
Yeah,
Okay, try screen sharing and other things so that in between technical hits has happened.
Just a minute.
You have been made the co-host, so in case if there is any disturbance, you can mute all and unmute yourself and continue the class. And
Perfect,
if you
sir.
want to ask questions, you let them respond in the chat box. Otherwise, if everybody starts to speak, it will be a disturbance. So if you want to find out question number 1, these are the choices, which choice you want to choose, they can mention it in like if it's they can mention in the chat box, and only few students will be there. So you can personally call their name so that they'll be feeling more comfortable and can appreciate them if it's a correct answer. Like that, you can proceed. Okay. So hope few more join. We have a technical assistant, and her name is IMA co-host. She'll be there full time. I don't know whether because of the thunderstorms my net may go. I don't know.
Oh, that's not a problem.
You continue. If there is any problems and I am not there in the group, you just feel free to call me over the phone. Okay.
Sure,
So
sir.
with net problem, I have to exit. I'll be available on the phone. Okay. So, okay. Right.
Right.
You can see the screen. No problem. You can see it.
Very good evening and a very warm welcome to another interesting session on a short subject, so-called short subject of ophthalmology. And welcome you all to this online CME series by IMA Signair. So this brief time that we're going to spend together, we'll try to make it as productive as possible for preparation for our entrance exam, that is NEET PG and INI-CET. So I'll introduce myself. I'm Dr. Niranjan. I'm currently a junior consultant at Nirmal Zai Hospital, and I'm a national faculty at Medico for the subject of ophthalmology. So with that brief introduction, I'll quickly jump to the subject per se. So now we are towards the fag end of the preparation. We're having exams coming up on June 15th and things. So there will be a lot of questions in your minds as to what is the kind of time I should allocate and what is the kind of material I should refer in this last minute, sir. So these are some of the questions that I would like to try to address before we straight away jump with the questions. So what are the few strategies I have for you for the subject of ophthalmology is you need to first manually and take some effort and write down the list of high yield topics in every subject, and so in ophthalmology as well. Okay, so now is not the time where we give 50 to 75 hours. Now, we are in a fast forward mode and a crash course mode kind of a situation, right? So what I would strongly recommend is to allocate maybe a day or if possible, a couple of days for revising ophthalmology, the entire of it, considering that we have almost a month and a half left before we jump to our NEET PG, right? And try to adapt yourself to the newer modalities and ways of questions, right? By that, I mean, try to make it more visual in learning and analyze the quiz questions, not the quiz questions, I mean the NEET PG questions. And you often see that they become more analytical and more application based rather than one-liners. And I think this trend has changed for quite some time now. And if you have certain weak areas in every subject from your past experience with entrance exams, if you're a post intern or you're giving your second attempt, try to focus on that areas at this point of time rather than going through the whole portions. Try to take maybe 2 to 3 grand tests maximum. And now maybe with 1.5 months left, maybe 1 grand test should be 1 or 2 maximum should be of help. And also try to reinforce the learning and identify the blind areas. Okay, so some portions are quite far-fetched because we've read it maybe only once or twice in our entire this thing. So that's why I said high yield topics really help. And now is not the time to make new notes and make study new material. Definitely not. You need to try to revise, and this is the period of revision and not trying to acquire new topics and new knowledge. And last but not the least, remember, this is a very crucial and a challenging time for everybody, all those who are appearing for NEET exams. So it's important to have a good positive outlook. Also try to make sure that you don't compromise too much on your health and your sleep, because on the day of exam, you got to be in your prime to give your best, right? So with these few strategies that I would like to share with you upfront, let us quickly move on to the questions. So how have I designed this crash course is everybody knows 2 hours are not enough to complete and compile the entire subject. But like I mentioned in my strategies part, I tried to touch upon some of the important aspects and high yield topics. And I tried to source them from previous year questions so that it is not that the same questions are expected to be repeated. Rather, it's about getting to know that these are the ways and the areas which can be asked, right? So that's the goal of our discussion today. So I would like to make it very interactive, and because it's a very closed small group, which makes it better rather than having a big auditorium with around 150 200 students or even 500, right? So I think that is the advantage of having such wonderful initiatives by IMA. So in this meeting, I'm going to make it more interactive, right? So I'm going to go question wise and we'll try to solve as many as possible in this short span of 2 hours, right? Good. So let us move on to the first question. So given image signifies which of the following conditions? So as you can see here, this is referred to as a 9-gaze image. Okay. So here they are referring to a 9-gaze image, and they're asking what is the probable diagnosis. So whenever they give an image, always try to understand as to what is that they're trying to ask by giving that part or that type of image. So here, when they give you a 9-gaze, you're expected to know that it is a squint question, right? And what you should try to see is start with the ortho gaze and see what is the ortho position. That is, in straight gaze, what are the positions of the eyeballs? And then try to act in your mind as if you're doing an extraocular muscle examination and see what are all the changes you're seeing here, right? So you can see that in this patient, in these, one second, let me just get the laser pointer so that all of you can be on the same page, right? So here you are seeing that this patient is having difficulty in adducting the eye, whereas the abduction part is pretty good, right? Similarly, the patient is also having in the ortho gaze, the left eye being slightly more ptotic or the left eye being smaller than the right eye. I hope you all can appreciate it, right? So that along with adduction being abnormal, okay, while abduction being normal. Is it clear? So what does this indicate? Anybody wants to answer? The more interactive you make it, definitely you still need not get it correct. Okay. What I'm trying to do here is trying to make it open for discussion so that we can all learn together. So maybe Rahel or Krishna or Meghna, anybody, one of you can unmute and share what do you think is the diagnosis. Don't worry about making a mistake because this is place to learn, right? Nobody? Shall I move on to the answer then? Right. So this is a typical case of oculomotor nerve palsy. Now, why would I say that? See, ptosis, adduction deficit, and two clues which I did not give you is, see this image. Can you see that the eye is not going down at all? That means the inferior rectus is also affected. Can you see? Inferior rectus is also affected. And at the same time, here, the eyeball is also not going up as well. So, superior rectus, inferior rectus, medial rectus, and levator palpebrae superioris. Okay. So, levator palpebrae superioris is a very important muscle that one must not miss out, that is supplied by third nerve or the oculomotor nerve, right? So, the answer here is oculomotor nerve palsy. Remember, it innervates 4 extraocular muscles: inferior, medial, superior, and inferior oblique as well. Okay, along with levator palpebrae and pupillary sphincter. So remember, if the palsy also involves the ptosis aspect, it is called complete ptosis. Okay, and it is called as a complete third nerve palsy. Okay, so there should be ptosis and there should be dilated pupil or mydriasis. If that is there, it is a complete third nerve palsy. But if one of these features are missing, it is referred to as incomplete third nerve palsy. Clear? So this is the way to diagnose an oculomotor nerve palsy. I hope now I made it clear. Sometimes what they do is, instead of giving you the 9-gauge picture, they will say that the eye appears to be down and out. Can you see the words that are given in quotations? What do I mean by that? So here the lateral rectus is still functioning because it is supplied by the 6th nerve. And the superior oblique, which is the depressor of the eye, okay, that is also working, whereas the medial rectus is not working. So the eyeball is out and down. I hope it is clear. So down and out eye is characteristic of oculomotor nerve palsy. Okay. Now, all are manifestations of dengue virus infection in the eye, except. Now, why have I put this question? See, the reason I put this question is because I want you all to know that as general medicine, or I would say MBBS graduates, we are expected to know little about everything than everything about little. And that is exactly what they try to test, because we are going on to become the postgraduates and we are going to become specialists. But at basic level, as an MBBS graduate, we are expected to know what are the changes in the eye that happens because of a systemic problem. You understand? So that is what you need to know. So here, all are manifestations of dengue virus infection in the eye except cataract, maculopathy, vitreous hemorrhage, and optic neuritis. Anybody wants to give it a try? It's relatively simple, isn't it? Nobody? Come on. One of you, you can unmute and share your thoughts. Ms. Beena, CJ, Junaid, anybody? Just give it a try. Definitely you may be right, wrong, we don't know. Anybody can unmute. Okay. No worries. I think we'll move to the answer. So, dengue viral infection has no association established scientifically with that of cataract. See, dengue is a neurotropic virus. Okay. And it is a platelet tropic virus. Right? So, remember, it is going to affect either of these two in certain ways. In whichever way we take it, right? Whether you're going to talk about nerves, you're going to talk about blood and blood vessels, crystalline lens inside the eye is avascular and aneural, right? So either ways, if it tries to attract the lens, the lens which is the natural lens inside the eye, it is not going to be able to do it, and hence it is not going to affect the crystalline lens and cause cataract. Is it clear? So manifestations of the dengue virus in the eye include maculopathy, vitreous hemorrhage, and optic neuritis. So remember, it is vascular in nature and neurotropic in nature. And these are all the different manifestations. So please do make a note, students, is that there is very much a possibility that they could ask the various ocular manifestations of systemic diseases and systemic infections and systemic medications. Okay, that is again a very important topic. Like, for example, for malaria, we give anti-malarial chloroquine, right? For DMARDs, I hope all of you know what is a DMARD, disease-modifying anti-rheumatoid drug, which is again hydroxychloroquine. All of them are notorious to cause chloroquine maculopathy, right? TB medicines, ethambutol, optic neuritis. So this way, whatever has an ocular relation is more than enough for the examiners to test you on that. Is it clear? Good. Right. So let us move on to the next question. A patient is taking drugs for rheumatoid arthritis and has a history of cataract surgery 1 year back. Patient presented with sudden painless loss of vision. What is the possible diagnosis? CME, which is cystoid macular edema, macular hole, chloroquine toxicity, and chronic choroiditis. Anybody wants to give an answer? Am I audible? Or is everybody online? Am I audible? Yes. Am I audible?
Yes, you are audible, sir.
Yes, yes.
Not audible right now.
I'm sorry. I think by mistake I had muted myself. So I'll go over it again. So I was saying that here there are two important clues. One is the patient is taking drugs for rheumatoid arthritis. Second is there is a very typical history of cataract surgery 1 year back. These are two important clues from the text. Third very important clue, or the most important giveaway of this question, is the picture. So whenever there is an image, always make an attempt to first understand as to what is the image. Can somebody unmute and tell me what is the investigation that is being done there in the picture? Anybody? Just, I don't even want the diagnosis. What is it? What is the test? Anyone? Just the name of the test. So it is basically FFA, fundus fluorescein angiography. Clear? So here what we are seeing is actually there is leaking and a very characteristic pattern called as flower petal pattern. Okay. So what do I mean by flower petal? This is the center of the flower. Okay. And along with the center of the flower, you are seeing the petals. Can you see this? So this is called as a flower petal pattern, which is characteristically seen in cystoid macular edema. Okay. So the point about rheumatoid arthritis could be taken as a mislead, or one more way to explain that is cystoid macular edema is an inflammatory process. Clear? It is an inflammatory process And a person who's suffering from an autoimmune disease like rheumatoid arthritis is expected to have a high propensity to have inflammatory disorders like cystoid macular edema. That is possible weakest link I can connect in this previous year question between RA and the picture and the question. But we all must remember one fact, that cystoid macular edema is a late stage complication of cataract surgery. Even if it is uneventful, that is, there is no posterior capsular rent, still it is a risk for cystoid macular edema, mainly a delayed complication. That is, you expect it to not happen the next day or next week. You expect it to happen at least 6 weeks, sometimes 6 months, or like this case, 1 year after surgery. Is it clear? So the answer is cystoid macular edema. The patient presents with sudden loss of vision, history of cataract surgery, and the fundus picture showing honeycomb appearance. That's another way to look at it. Honeycomb or flower petal, which are all indicative of cystoid macular edema. Okay, and honeycomb is what you see in fundus. Flower petal is what you see in FFA. Okay, right. Hypofluorescence can occur secondary to a blocking effect or because of a vascular filling defect. We don't have to get into the details of these. Just know that there is leakage and that takes up this shape. Okay. Clear? So now let us move on to the next question. Before that, just a quick note on what are the different types of angiographies available for the eye. If you want to study the blood vessels that are running in the eye, what is special about these blood vessels? Can anybody tell me? Blood vessels in this retina? Remember, retinal arteries are end arteries, meaning just like we have it in kidney, they are end arteries, that is, they do not have collateral circulation or a dual blood supply. Why is it important? Because any source or possibility of hypoxia, atherosclerosis in the bigger vessels, these vessels are going to suffer drastically. Number one. Number two, about retinal vessels, these are the only vessels in the body which can be directly seen live without having to make an incision or any special maneuvers. They can be literally visualized. Okay. So live pulsating vessels, where can you see in the body? The only place is the retina. There? Good. Now FFA and ICGA. So these are the two different dyes. Okay. So fluorescein dye and indocyanine green dye. Okay. So one is for retinal circulation, one is for choroidal circulation. Remember one point of difference that you must know. ICG is highly plasma protein bound, meaning it does not easily leak like we saw in FFA. Okay. Hence, it is restricted to the choroidal circulation within the blood vessels and helps us understand choroidal diseases better. Okay. What are the kind of filters you use? All that is little technical, but just remember that ICGA also exists. Nowadays, there is a newer non-invasive method of angiography, which is called as OCTA, which is optical coherence tomography with angiography, OCT angiography. Clear? So there, you need not inject any dye. Without injecting dye, you will be able to visualize the vessels. Is that clear? Good. Now, another understudied or least touched topic, optics and refraction. So remember, students, optics and refraction is supposed to be the bread and butter of every ophthalmologist. So as an MBBS graduate, the bare minimum we should know is be thorough with all the types of refractive errors. Okay. Refractive errors and its types are a definite must to be known. Clear? And how do you do refraction? All of that is also, can be clubbed under essentials, but at least the different refractive errors, their causes, how do you treat them is a definite must know topic. Okay. Now, I'm not sure how many of you have heard about this equipment called as stenopeak slit. So stenopic slit is used for all of the following except. Remember students, all except is a very fond style of questioning by entrance exams, because that requires you to know much more about the topic than a straightforward MCQ, right? It is one of the easiest ways where the examiner can turn a simple question into a conceptual question. Is it clear? So that is what I wanted you to know, right? So stenopic slit is an equipment used in optometry. And what is it used for? It is used for all of the following except. Anybody wants to give it a try? Have you heard of these names before? Yes, no? Someone wants to give it a try? Anybody? Let me try to show you the equipment. This is how it looks. Oh, it has the answer also. Right. So remember, the whole refraction is very much dependent on what is the actual amount of light that is entering the eye. Okay. So anybody knows what a pinhole is? Pinhole testing. You definitely would have, either those who are wearing glasses, they would have tested it on you yourself, or if you would have attended your clinics, this part of the evaluation is must. Pinhole, anybody? Whatever you know about pinhole.
Yes, sir, we have done it.
Fantastic. Good. I'm very happy that you've responded. Good. So pinhole, what it does is, basically remember, any ray of light that is entering the eye, what happens to the ray of light? It undergoes refraction. Correct? In cases of refractive errors, there is a problem with the amount of refraction that the eye is undertaking. It's more or less. Okay, it's either too much or too less. Now, there is one single ray of light that passes through the center of the pupil, center of the cornea, and center of the lens, which goes undeviated. How is it? Goes undeviated. So that pencil of light or ray of light, correct? That is going to go and hit the fovea on the center of the macula without undergoing any refraction. Clear? So what does that result in? That means the central ray is going to be unaffected by the refractive error. So in which case is, or why do we have to be bothered about the central ray? Because any opacity, okay, any opacity in the center of the lens or center of the cornea is not going to allow this central ray of light to reach the fovea. Is it clear? So if the patient's vision is not improving with pinhole, that means the patient is having a media opacity. That could be corneal opacity, that could be cataract in the lens, or that could even be macular edema. Clear? Now, the same thing, the same concept, you extrapolate it into a slit. That is stenopic slit. Clear? So, the stenopic slit is actually an opaque trial lens with an oblong slit, which functions like a pinhole, and it functions to prevent or cut off the rays from the other axis. So what is the point? The axis in which the patient is able to see best, right? That is the axis in which the refraction needs to be done. So in case there is any irregular astigmatism, corneal opacity, okay, then this refractive error cannot be corrected just with glasses. Okay, so that is what you need to know about the stenopic slit. Clear? So how is it useful in these conditions if you ask me? What is Fincham's test? Fincham's test is if a patient has colored halos. The colored halos tend to break or do not break. Okay, this is a homework for all of you. Okay, you have to go and see which are the conditions in which the halos break and which are the conditions in which halos do not break in Fincham's test. Fincham's test is a clinical test, so there is a high possibility that they can ask that. Second, axis of the cylinder can be determined. I told you how. Iridectomy, remember, you do an iridectomy where there is maximum amount of light that is passing through. Now, let us say there is corneal opacity and it is not central and it is one corner. You do a slit and try to see at which axis is the light maximum entering. And in that axis, you do an iridectomy so that the light can pass through that and have the maximum potential vision for the patient. Now, this was done in olden days. Nowadays, we have a lot of corneal procedures, but olden days, they used to do simple iridectomy rather than trying to replace the entire cornea. Clear? So these are the uses of stenopic slit. Next question. When should a patient with type 2 diabetes for 1 year with no other complications have ophthalmic examination? So this is a very factual question. Okay. So this is a, or don't know kind of a question. There's no concept here. These are certain guidelines that have been recommended for appropriate screening of patients suffering from type 1 and type 2 diabetes. Anybody knows? Anybody wants to give it a try?
As early as possible.
Fantastic. Superb, superb. Very good. Can anybody tell me why?
Sir, because diabetic retinopathy is sometimes not detected early. Therefore, like during the first visit itself, when diabetes is detected, you need to send them for ophthalmology.
Fantastic answer. Fantastic answer, doctor. Yes. So type 2 diabetes mellitus is often the disease itself is diagnosed pretty late because it doesn't present in a very dramatic and a cinematic way like a DKA we see with type 1. Okay. So they get diagnosed much later and often than not, they present to the doctor with diabetic complications and end up being diagnosed as type 2 DM rather than getting checked up much before that. So you wouldn't believe me if I told you that in my practice, there are several patients who are diagnosed as diabetes after they present to us with blurring of vision and have been diagnosed with non-proliferative diabetic retinopathy. Clear? So that is the reality and the sorry state of affairs. However, in type 1, there is a different guideline. So see, according to the Indian guidelines, type 2 diabetes should be examined at the time of diagnosis and then annually after that. Type 1, they say, should be diagnosed or should be screened for DR, diabetic retinopathy, at least within 5 years. Within 5 years of the time of their diagnosis. Clear? If the patient is not properly, controlling his or her glycemic status, then it is worth screening him more frequently until it stabilizes so that you do not miss out any dire complications of diabetic retinopathy. Is that clear? Now, the following test is used for the assessment of, have you ever seen this book before? Very recently, I came across this book in one of our conferences, and you wouldn't believe me if I told you this book costs around 5,000 to 7,000 rupees per book. No, sorry, 5,000, 10,000. Anybody knows what this is? This has been asked. I have pulled out all these questions from previous year papers, so it's not like I'm asking you out of the world questions. Anybody? So this is referred to as the titmus fly test. What is it? Titmus fly test, and it's very useful for stereopsis. So the given picture is titmus fly test and useful for stereopsis. It is used to quantify the extent of stereopsis and measure stereoacuity. Okay. Don't get into the details because it's a little tricky. It works on the principle of dissociation of images between the eyes and by using different colors, etc. But one thing I want you to know is Titmus fly test is for stereopsis. Is that clear? Then what is it for color vision? We need to see any MCQ discussion. Always remember you need to be a little bit aware of the other options also. You shouldn't completely miss out on not even knowing what the other options are. Can somebody tell me how do we test color vision? This everybody will know.
Ishihara's.
Fantastic. Ishihara's. Any other test you know of? Named test. It can be asked. Which of the following is not used in color vision testing? Ishihara's could be one option. What else? Have you heard of green lantern test? That is one other name. Farnsworth Munsell 100 hue test. Okay. Farnsworth Munsell 100 hue test. So what I want you to do is just, you have mobiles, just type these names and just see the image. It is worth it. Okay. Because these are all tests which are much more sophisticated than the simple Ishihara's. Okay. So just for your information, visual field, how do we test? Anybody? How do we test for visual field? Bedside test. Investigation. Bedside test, investigation. Anyone? Have you heard of the confrontation test? Confrontation. We make the patient sit in front of us. This is taught to us in neurology, physiology. Remember? So this is called as confrontation test. On the other hand, for investigations, we do a Humphreys visual field analyzer. Humphreys visual field analyzer. Good. Okay. Now, let us move on to the next question. Okay, so this is a little bit about binocular vision. Okay, binocular vision has 3 parts to it. One is fusion, binocular perception or simultaneous perception, and stereopsis. These are the 3 grades of binocular single vision. Okay. Right. This question. A patient presents to us in the trauma center with an injury to the eye as shown in the image. Which of the following steps should not be done during the initial evaluation? Anybody? This is very
Just
easy.
removal of foreign body, sir.
Correct. Correct. Why would you not want to remove the foreign body? What are you scared of?
So while maneuvering, we can damage the cornea.
Verb answer, doctor. Yes. See, primum non nocere, forensic medicine. First, do no harm. Okay. So even if you're not in a position to treat the patient, do not mess around with him and end up causing more damage to him. Okay. So that should be your goal rather than just trying to do something in the name of treatment. So here you need to assess the vision because vision can deteriorate even within a day. You wouldn't believe me. There was a patient similarly with initially having almost 618 vision. But while, this was from a periphery where I don't know whether they documented it right or wrong. That's another question for another day. But when they presented to us, they had only perception of light. So we were confused. Then we asked the patient and they told us, doctor, while coming, this was a little bit of a rod like this thing. We ourselves tried to remove it after, visiting the doctor on our way back here. So unfortunately, he or she might have ended up damaging some important part of the retina or the optic nerve while trying to do that, right? So this is why documentation of vision becomes important. Primary survey, yes, you need to assess whether the patient has any other more serious life-threatening injuries. That could be a possibility. And antibiotics, of course, you need to start the patient on because the earlier you start it, the less chances of the infection, completely taking over and ravishing the eye, right? So you definitely should not remove the foreign body. Especially if it's penetrating into the globe, no attempt should be made to remove the material prior to an ophthalmic consultation as it may lead to leakage of intraocular contents. Not only inside content coming outside infections will traverse easily into the depths of the eye and it's not going to be easy for us to deal with that because the deepest portions of the eye are not extremely vascular. Even if you pump the patient with antibiotics, it is not expected to reach the site of infection in that concentration that is required to kill the organism there. Okay. So in addition to reviewing the history, ophthalmologists will perform an external examination, reassess visual acuity, pupillary responses, assess ocular position, in the orbit, see if it is dislocated. All of that needs to be done. But remember, even in certain situations, it can be another option. That's why I'm mentioning it to you. You may even be expected to do a CT, not an MRI. It is an iron foreign body, not an MRI. Do a CT to see the extent of damage and penetration this iron nail has caused. Okay, whether it's going and breaking the posterior, apex of the orbit, entered into the cranial cavity. All of these needs to be assessed. And believe me, by doing that and the time that takes, it is not going to damage him more than you trying to immediately get rid of the foreign body. So a CT before removal is mandatory. Clear? So further management include topical antibiotics, topical cycloplegics to reduce the pain. Okay, immediate effect of extraction of foreign body is good, but prognosis should be guarded. The tracts through which the vitreous may become filled and with fibrous tissue, and this becomes a problem later on due to contraction. So in spite of doing it under well-planned operation setup, OT setup, always we must warn the patients about the guarded prognosis, because the process of damage is not going to cease there. We are just reducing the intensity by removing the foreign body. However, the damage can continue to happen in the process of inflammation, and further visual deficit can occur. Okay. Now, remember the classification of eye injuries. Closed globe, open globe. Closed globe further divided into two types. One is a contusion, which is because of a blunt force injury. The other is a lamellar laceration, where the globe has not been ruptured through all layers and the interior is not communicating with the exterior. It is a lamellar, partial thickness. Okay. On the other hand, open globe divided into laceration and rupture. Okay. It is further divided into penetrating, where there is a through and through injury, but the foreign body does not have an exit wound. If it has an exit wound, it becomes a perforating injury, like we've learned it in forensic medicine. Nothing, unusual or abnormal. And lastly, intraocular foreign body, IOFB. Okay, so these are the various types of ocular injuries. Another important topic, students, most common route of spread of retinoblastoma. Anybody knows? Come on. This is easy, straightforward.
Neural spread.
Amazing, amazing. Good one, doctor. Good one. So, what neural are we talking about? What nerves?
Optic nerve.
Exactly. So, it is a very straightforward question. And it is important as an ophthalmologist to know this. Can anybody tell me why we need to know about this spread and how is it used, or how is this piece of information used clinically? Anybody knows? Remember, optic nerve, a piece of optic nerve about 1 centimeter. Okay. 1 centimeter of the optic nerve is removed along with the eye globe when we are doing enucleation for retinoblastoma. Clear? 1 centimeter of the optic nerve is removed because at the tip of that specimen, okay, we must ensure that there is no tumor cells. If there is tumor cells, then the prognosis is guarded. Clear? So that is why we need to know about the neural spread. Okay, the neural spread of retinoblastoma. So basically it has 4 patterns. The most common pattern is direct invasion along the optic nerve to the brain, can also see the orbital tissue on its way, and also invade the adjacent bone. Tumor cells which have invaded the optic nerve and the leptomeninges then disperse into the adjacent subarachnoid fluid, and characteristic pattern of, that is a second characteristic pattern of metastasis through the CSF. The third pattern is hematogenous through the blood vessels, and last but not the least is through lymphatic spread. Most common is direct spread. Is it clear? Retinoblastoma, remember, is a very common topic because it is quite life-threatening for very innocent population of kids. So highly disheartening for an ophthalmologist to miss out on retinoblastoma, right? So, and it is a very common prototype tumor. We've learned it in pathology also, right? Pathology also, we've learned it in, so much depth and detail because of the RB gene. So, very potential topic as well. Okay. Now, another image-based question. Identify the abnormality, all of you. Anybody? And I also want you to share as to what is the other options. No, just take it in, one step at a time. Answer the question, then tell me whatever you know about the various options. Come on, quick. See, I have around 25-30 questions. So the faster you answer, we're going to cruise through the rest of it and try to cover as much as possible.
So is it KF ring seen in?
Good attempt, doctor. Good attempt. Fantastic. Anybody else wants to give it a shot? See, KF ring stands for?
Is a fleshes ring.
Correct. Where do you see that?
Wilson's disease.
Superb. Very good answer, doctor. Now, which part of the eye do you expect to see it? Retina, cornea, lens.
Cornea.
Exactly. Where do you think
got
this
it.
ring is? Where do you think this ring is?
Is it lens?
Exactly. Correct. So that is one reason why this is not KF ring. Okay. And remember, KF ring is in the cornea. It is in the periphery of the cornea, very close to the limbus, demarcated by a clear zone. Okay. Whereas this is seen in the anterior lens capsule. Anybody wants to try?
Is it Vosh's ring?
Superb. Yes, doctor. It is Vosh's ring. Where do you see Vosh's ring? Fantastic. Now, if you're going to answer like this, we'll quickly cruise through all the questions and finish it off and, say good night. Tell me, which condition do you see Vosh's ring? Remember, any case of blunt trauma, okay, the iris is going to go and hit against the anterior lens capsule. Blunt trauma, right? So remember, you may be seeing the front of the iris to be nice and brown in color, but you know the irony? The back part of the iris is much more pigmented and darker, and those pigments get stuck onto the anterior lens capsule, and then the iris gets released. So that is referred to as the Vosh's ring, and it is a sign of blunt trauma. Okay, where do you see V's ring? V's ring is seen in the vitreous cavity when there is posterior vitreous detachment from the margins of the optic disc. When the vitreous gets detached from its area of attachment around the optic disc, that is referred to as V's ring, which the patient will perceive as a circle-shaped floater in his field of vision. Is that clear? And lastly, Fleischer's ring is also seen in the cornea. It is seen in a condition called as keratoconus, where there is deposition of iron within the Descemet's membrane. Okay, so these are the various rings we learned about it today. Here I've just mentioned about Vosh's ring, but always remember to learn about the various options as well. Is that clear? Okay. So see, what are all the various impacts or damages that happens in the eye following injury? So let's start with one. First is iris sphincter showing radial tears. Second is the base of the iris getting detached, and that is called as iridodialysis. Third is the anterior ciliary body getting detached from its insertion. That is called as angle recession. Then the ciliary body getting detached from the ciliary spur. Okay, that is cyclodiastasis cleft. Trabecular meshwork in the angle having tears. Zonules getting displaced leading to lenticular or lens subluxation or dislocation. Lastly, the ora serrata being damaged leading to retinal dialysis. Can you understand how wonderful this picture is? It gives you all the possible consequences of injury in the eye following trauma. Is that clear? Right. Now, another very interesting question. I was telling you, remember, it's important for us to know the side effects of various medicines and their thing. I think it'll be difficult for you to answer this, so I'll move on to the answer. So remember, amiodarone has corneal microdeposits. Okay, it has it in a shape of a world. Okay, in the shape of a vortex. It is called as cornea verticillata. Okay, cornea verticillata or vortex keratopathy. Okay, second, digoxin is known to cause xanthopsia, that is yellow vision. The exact mechanism is not clearly understood. Okay, systemic steroids is notorious for causing cataract, and hydroxychloroquine, I already told you, causes chloroquine retinopathy. Is it clear? So these are the various types of systemic medications which can cause ocular manifestations. Okay. So yeah, one of the most common drug deposits found in the cornea is from the cardiac medication amiodarone. Deposits in the inferior and central cornea in a whorl-like pattern called cornea verticillata, appears as fine tan or brown pigment in the epithelium. Okay. So these are some drugs and their consequences. This is an interesting question which was found in the papers. Anybody knows? Most common ocular symptom in COVID-19. We in fact were COVID batch postgraduates. So in the year of 19 and 20, 20 and 21, we were actively involved in post-graduation, and we were doing and facing a lot of these cases as well. Anybody? Whatever you know.
Keratouveitis.
Okay, good. See, remember in fact, all of these were seen, but the most common was follicular conjunctivitis. Okay. So it is basically the pink eye. Okay. So the conjunctiva, which is actually the transparent layer, was involved and inflamed, just like we have adenoviral infection causing Madras eye. You would have heard it of it, no? Acute catarrhal conjunctivitis. So COVID-19 also had a similar manifestation. Next question. Very interesting question again. Which of the following statements are true statements regarding primary open angle glaucoma? Abnormality of trabecular meshwork is seen on gonioscopy. First degree relatives have more chances of developing steroid-induced glaucoma. Dilatation of pupil is associated with exacerbation of IOP. First degree relatives are at 1% increased risk of POAG, and visual field deficit can exist even with normal CD ratio. How easy is it to understand these options, students? Is it confusing, very difficult to decipher as to what they want to ask? See, these are questions where you need to take a pause, take a deep breath, even amidst your busy NEET exam, and read one option at a time. Okay, I'm not going to do the entire exercise of reading that kind of a question now because of lack of time. But always remember, do not be hasty in trying to answer these kind of questions, because these are areas where you will tend to get confused even with simpler things. Now let us see what the answer is, and I'll explain as to why I'm taking this kind of or giving you this kind of an advice. So the option is actually only 2 and 5. All the other options are just to confuse you. Okay, this was seen in one of the INICT papers. So do not be under the illusion or impression that just because they're giving you options and giving you an option to choose all the options, like this, all of the above is a very, very favorite option, as they say it, right? Do not have that bias or prejudice. Okay, give the question its merit. So what you try to apply. I was telling you, analytical and application based. So see this question. 2 and 5 is the right option. So we need not explain as to why it is, right? Yes, they have an increased propensity to steroid induced, and visual field deficit can exist with a normal CD ratio because about 60% of the damage to the neuronal cells should have happened before you expect an obvious clinical increase in the cup disc ratio. So that is why we are struggling day in and day out to identify what are the possible ways. What are the possible ways to try to identify glaucoma before it inflicts such amounts of damage, right? So what are the wrong options? Abnormality of trabecular meshwork seen on gonioscopy? No. The angles are open. You do not see trabecular meshwork to be abnormal. And remember, these are blockages in the trabecular meshwork that are happening at a very microscopic level and not something you can appreciate using gonioscopy. So that is wrong. Second, dilatation of pupil is associated with the exacerbation of IOP in angle closure glaucoma, not open angle glaucoma. And first degree relatives are at 1% increase. No, they're actually at a higher risk, around 5 to 10% risk. This is a little, too much of numbers, the fourth option, but the other two are pretty conceptual. And even if you do not have to be bothered about, the fourth option and the number, because you see, the fourth option being correct is only in one option. That is option A. So, 1 and 2 are not right. You're not going to choose option A anyways. So, there is no option as 2, 4, and 5. Did you notice that? If that was an option, then definitely these people want to mess around with the numbers and, don't want us to get it right. So, eventually, if you know what is wrong, you understand? If you know what is wrong, a lot of the options get eliminated and you're left with a very few options. Is that clear? So don't be disheartened about the fact that you may not be aware of the percentage of the risk of POAG in first degree relatives. No, you cannot humanly remember all the numbers in every 19 subjects. So don't let this question and the fourth option demotivate you. That's what I'm trying to say. Is that clear? So yeah, I told you, right? 10% in siblings and 4% in the offsprings. Right. So first degree, that is different. This is 10 to 20%. Clear? 10 to 20% is the first degree relative risk. Now, next question. A very similar question. Do you want to attempt it? Anybody? So don't jump to any conclusions with anything. Just openly attempt this question and give me the answer. A, B, C, or D. No answer. Shall I move on to the answer then? Just like we saw in the previous question, right? So we need to know about pilocarpine and its uses, which is a part of ophthalmic pharmacology, correct? So that if you know, you are very much in a comfortable position to say what is the answer. You need not bother about knowing about epinephrine and codeine. We don't use codeine at all. And even nowadays, epinephrine is also not something that is commonly used. So none of this is what shall I say? Is a confusing option if you know what is right and what is wrong. Okay? Is that clear? Now, this is a small flow chart which is often used in routine practice. I just put it up here not for you to remember everything, but what I wanted to highlight here is the use of pilocarpine. See, diluted pilocarpine 0.125 and pilocarpine 1%. Instead of epinephrine, what is used is actually an alpha-2 agonist, which is the apraclonidine. Okay, apraclonidine is used, and that is useful in differentiating between Horner syndrome and physiological anisocoria, not phenylephrine. Is that clear? So this is what I wanted to highlight using this question. A 55-year-old man has undergone LASIK for myopia. What is the best method to check for IOL power calculation? Anybody? These are all no or don't know questions. There is no concept here that you should delve into and deep dive into nothing doing. Just give it a shot and I'll move on to the next question. Come on, anybody? Have you even heard of this formula? SRK, everybody would have learned. Answer is Huygens formula. Okay. So remember, as and when the axial length is going to change, you got to use the appropriate formulae to try to identify. But nowadays, all of these factors are taken into consideration and there is one formula. Anybody knows the name? Any one of you? Barrett universal formula, and that has a Barrett universal formula type 2. Now there is a second also. Okay, not just one. There is Barrett universal formula 2. Am I clear? So that is about that. So this is a small table. If you want, you can take a screenshot where based on the axial length, the formula that is used for calculating the IOL power varies. Okay. Right. So next question. A patient is prescribed an eye ointment and an eye drops by the nurse. What should she advise about putting them or using them? This, would you want to give it a shot? See, can you see that how practical things are getting as we go down, right? Nowadays, the emphasis is not about knowing hardcore, unusual facts. These are things which are used routinely in daily practice and hence expected to be known by MBBS graduates. Which one would you apply first, ointment or drops, and why? Come on, these are things you need not know, right? I mean, you need not know from before. You would have seen in your clinics, or you yourself might have used eye drops, and you might have received some instructions from the doctors, right? Anybody? You can see some names here. Dr. Libin, Dr. CJ, Dr. Rahina, Dr. Kartika. Okay, I'll go for the answer. So always remember to apply the drops first and then the ointment. Mainly because drops have the characteristic nature of being available for immediate action, but are diluted by the tears very quickly. On the other hand, the ointment takes some time for the onset of action, but stays in the eye for long because it is not diluted easily. So ointment should be followed with, the drop should be followed with an ointment. Is that clear? And often this 15 minutes is given for the drops to start its action. Okay. In some books, there is also mentioned about 10 minutes. That kind of a variation is there. But what is most important take home is from this question is drops first, then ointment. Okay. Right. So what are all the various ways in which a medicine or a drug can be delivered to the ocular surface or the eye? First is eye drops, simplest and the easiest way to do it. It is available as aqueous solutions or suspensions. If it's available as suspensions, shake well before use. Okay. Drug is available for immediate action but quickly diluted by tears. Ointment is available but it's not for immediate use. It takes some time for the onset. And problem with that, it is blurs the vision. Gels prolong contact but do not cause much of blurring. Ocucerts are those which deliver it through a membrane. And lastly, soft contact lenses are available for certain medications which deliver the medicine over a long period of time. Is it clear? So I hope I made myself clear with this. So these are the ways of administering a drug to the patient according to the need and compliance. Next question. A child is presenting with a left-sided head tilt. When doctor corrects that, he notices right hypotropia, which increases on dextroversion and right head tilt. Which of the following muscle is paralyzed? Tough, no? Squint is always tough. But I'll tell you certain easy ways to do it. Anybody wants to give it a try before I jump to the answer? Just give me 2 minutes. Keep pondering over this. I'll be right back. There is some connectivity issue and I'm also getting a call. So quickly think about the answer. I'll just rejoin and I'll be online. I'll just get back to you people in 2 minutes. Yes. So I'm back. So is anybody ready with the answer to the question? So remember, whenever there is a squint question, always try to find out the most important key point. Meaning, we should try to identify as to what is the kind of squint that they're talking about. Is it a horizontal squint or a vertical squint? That's the first point. Okay. So here, the moment there is a head tilt, right? Head tilt meaning it's a vertical squint. So for this, we are going to talk about a test called as Park's three-step test. Okay. So remember, on the first step is an ortho gaze. Okay. In the ortho gaze, which is the eye that is looking down? Okay. Hypotropia. That is right eye, right-sided hypotropia. Now, when the patient is having dextroversion, that is the patient is trying to look to his right. Correct? In that case, the hypotropia is worsening or increasing. Okay. And they are also saying that it becomes worse on right head tilt. Okay. So that is the third step. So version is the second step. This is the third step. Remember, whenever there is a head tilt, it is most likely a case of oblique palsy. This is the catch point that I want to convey to all of you. Okay. So oblique palsy results in a head tilt. But we don't know whether it is right or left, whether it's superior or inferior. Often this head tilt, if it's happening in the inferior, is eventually going to involve the other extraocular muscles also, because it is also supplied by third nerve. So if they're talking about head tilt, eventually remember it is going to be the superior oblique, and it is a fourth cranial nerve that is involved. Do you understand how I narrowed it down? It's slightly complex, but I've tried to make it into simpler three-step process. Now, dextroversion. Remember two mnemonics that I'm going to share with you now. This is not something that I have prepared. Rather, this is advised in the Bible of, I wouldn't say Bible, the most common textbook of ophthalmology, which is Kansky's ophthalmology. The mnemonic is WOOG. Okay, WOOG and boot and boot. Okay, what is WOOG? Worse on opposite gaze and better on opposite tilt. Now, if you ask me, why am I loading you, or with among the so many mnemonics, why am I dosing you with one more? See, if you want to know which is the side of the palsy, whether it's a left-sided superior oblique or a right-sided superior oblique, it is important to know this mnemonic. So if, let us say, the gaze, okay, is going to be on the right side, right? So it is right side that makes it worse, and it is the right superior oblique. Okay, but here the head tilt is also going to involve the better on opposite tilt, correct? So BOOT, that is boot. Okay, so better on opposite tilt. So in this case, if you're suspecting a right-sided hypotropia, it should get better on left head tilt. Okay, that is satisfied because it is becoming worse on right head tilt, meaning it is better on left head tilt. But if you're suspecting right, it should become worse on left gaze, because worse on opposite gaze, correct? So in that case, this is not fitting into an oblique palsy. Okay. So now, when you're talking about a vertical diplopia, and it is not fitting into an oblique palsy, then eventually it has to be a rectus palsy, and that is why it is right superior rectus. See this, the function of the right superior rectus is elevation, adduction, and intorsion. The child presented with a left-sided head tilt with right hypotropia on correction. That is, when you correct the tilt, it becomes right hypotropia, which increases on dextroversion. It is if it's increasing on levoversion, then it is superior oblique and right head tilt. So the muscle paralysis is superior rectus. Now, what I want you to do is this question, I want you to go through it again, maybe later, and try to check in the internet for Park's three-step test. Park's three-step test and try to understand it. Because if it's a superior oblique palsy, that is the only test that is going to help us, and that is through this Moog and Boot. Okay, right. So that is why I wanted to put that. Remember, isolated palsy is usually congenital. That's why the child was given as an example. The paretic eye is affected in elevation and abduction. The elevation is limited in the primary position, and that's why the patient had a right hypotropia, but it is normal on adduction. The paretic eye is hypotropic in the primary position. Frequent torticollis. Child has torticollis, you should not come to a conclusion of squint. Usually associated with weakness of levator palpebrae superioris, and the patient may have pseudotosis. And lastly, contralateral inferior oblique overaction is expected. This overaction, underaction part, don't, it's even complicated for a postgraduate, so let's not jump into that. But remember, hypotropia can be because of two things. One is superior oblique or the superior rectus palsy. Okay, so that is what you need to understand. Clear? So this is about the actions and the nerve supplies. This much you are expected to know. Okay, the action and the nerve supply is a must that every person appearing for the exam, because this is a part of anatomy, this is a part of physiology, this is a part of ophthalmology, this is a part of neurology. So this cannot be skipped, and one way or the other it's going to be asked in your exams. And this is another very wonderful schematic diagram trying to explain to you the various actions of the various muscles in their respective positions. So you can of course take a screenshot and analyze this picture. This picture is very easy to be brought in your mind at the time of exam and answer the question swiftly. So that is why I have put this picture. Next question. Identify the procedure shown in the given image. This is very easy. Quickly answer. We have a lot more questions to cover. Anybody? Am I audible? I think I am. So I can see the mic moving. What step of the procedure is this are we talking about?
The capsular axis.
Superb, superb. That's it. There's nothing, there's no rocket science to it. It is capsular axis. So it is CCC, continuous curvilinear capsular axis. Remember that this is the first step in trying to open up the bag in which the cataractous lens is present, and then it is aspirated and emulsified, and then IOL is placed. Next, if the numerical aperture of the objective lens is increased, what changes is expected in the image? This is a little tough, isn't it? What am I talking about? Anybody? If anybody can guess what am I talking about, then I'll quickly say the answer. What objective lens are we talking about? This is a part of the slit lamp. Okay. So part of the slit lamp, there are two lenses. One is known as the objective, the other is known as the eyepiece. Okay. When the numerical aperture is improved, what happens to the image? So it increases magnification. So from 10x to 16x to 24x. Okay. When you increase the numerical aperture, then basically x refers to the number of times of magnification. So high power objective is known as the high dry objective, and the oil immersion objective can even go up to 100x. Okay. So this is a very objective question, highly unlikely to be repeated. Just letting you know the different parts of slit lamp. Okay. So see, this is what I was telling you. So these are the different types of ways of increasing the aperture. Now, next question. Yeah, this is another important point. See, remember, community ophthalmology is common between ophthal and PSF. So again, that is very potential to be asked in the form of NPCB. So what is the most common cause of moderate to severe visual impairment according to the National Blindness and Visual Impairment Survey? Anybody? Most common cause of moderate to severe visual impairment. See, it cannot be glaucoma. Less likely to be diabetic retinopathy. Either it's untreated cataract or refractive error. Take a pick.
Refractive error.
Okay. Anybody up for cataract? Okay. The answer is cataract. Because remember, refractive error is coming up nowadays in big way. We are talking about 2015 to 2019 survey, where the exposure to gadgets in the pre-COVID era was much lesser. There are several studies to back it up. And so remember, cataract is a process of aging. So that is definitely more than refractive errors. Also remember the various types of blindness. Please make a note of this table. Simply, they can ask you what is the visual range for economic blindness? What is the visual range for social blindness? Okay, that is why I have put up this table here. So do make a note of this. These are all know or don't know type of questions that can be asked. And this is WHO and NPCB that we're talking about. So it's not completely out of syllabus or not expected type of questions. Is that clear? Next. A farmer presents with pain and discharge in his left eye. He says he sustained injury with a leaf few days back. What does the finding seen in the image? Come on. These are all very easy, straightforward questions. Your answer.
Hypopyon.
Super. Fantastic. So it is a hypopyon. So what type of ulcer do you expect in this patient? Bacterial, fungal, viral, protozoal.
Is it
Remember-
fungal, sir?
Yeah, correct. What is it?
Fungal.
Super. So anytime there is involvement of organic material in the form of leaf, branch, twig, mud, okay, all of them are more likely to cause fungal. Okay. So it's highly suggestive of ocular infection. Accumulation of pus in the anterior chambers refers to as hypopyon and characterized by accumulation of pus in the anterior chamber. Remember, fungal corneal ulcer, the hypopyon will have fungal elements. So it is not sterile. Whereas bacterial hypopyon, it will not have bacteria in it. It will have only inflammatory cells. Hence, it is sterile. This difference you must know. Okay. Fungal corneal ulcer, the fungi have the ability to penetrate into the cornea and get deposited in the hypopyon, whereas bacteria, they do not have the tendency to penetrate, except for certain bacteria. Can you tell me two of them which have the capability to penetrate an intact cornea? This again is a question. Anyone knows? Anybody knows? Corynebacterium diphtheriae, Neisseria gonorrhoeae, and Haemophilus influenzae. Some books say even Listeria. Okay, good. Next question. Which of the following statement is true about optic neuritis? RAPD is seen. No pain in ocular movement. Multiple myeloma is the most common cause, and oral corticosteroids mainstay. This is a sure shot topic. You have to know about this. Anybody? Come on, quick. We are only, I think, 10 questions away. Oh, no, not even 10. I think 5 questions away. One characteristic feature of optic neuritis would be RAPD, relative afferent pupillary defect. So option A is the right answer. So what are the other options for? See, characteristically, there is pain on extraocular movements in optic neuritis. Is that clear? Why is there pain? Because whenever there is optic neuritis, the nerve sheaths, okay, the dura mater, arachnoid matter, and pia mater, which is covering the optic nerve, also continues to cover and is in continuity with the muscle sheath that is covering the superior rectus. Okay, so anytime the eyeball is going to move, because the optic nerve sheaths are inflamed, even the superior rectus sheath is also inflamed, and an inflamed muscle sheath elicits pain when being stimulated. Is that clear? Am I clear? So that is why there is pain on extraocular movements. It is not multiple myeloma, but multiple sclerosis, which is the most common cause. See, these people are so fond of doing bird jugglery. Multiple sclerosis, which is an autoimmune neurological disorder, whereas multiple myeloma is a hematologic neoplastic disorder. And lastly, it is not oral corticosteroids, but intravenous methylprednisolone, 500 mg IVBD for 3 days, followed by oral corticosteroids, prednisolone, 1 milligram per kg body weight, okay, once a daily for 11 days. So it is a 14-day regimen that is prescribed across the world by ONTT, Optic Neuritis Treatment Trial. Clear? So this is the explanation. So RAPD is seen, which is also called as Marcus gun pupil, which is a clinical sign observed in optic neuritis. This occurs due to an impaired neurological response in one eye, where the affected eye shows a reduced or an absent response. So how is it elicited? It is elicited using swinging flashlight test. Okay. Next question. Which of the following atropine contraindicated? This we learned last time in the previous questions. Can anybody answer? This everybody knows. If you answer, we go on to the next question. Quick. Come on. Anyone? I'm sure you know this. Why do you not use atropine in glaucoma? What does atropine do? Anybody?
Atropine dilates the pupil and worsens.
Fantastic. So whenever there is dilatation, there is going to be crowding of the iris in the periphery, leading to closure of the angle. So you should not use it in acute congestive glaucoma or acute angle closure glaucoma. So atropine is contraindicated in acute angle closure glaucoma. Clear? Which is also called as acute congestive glaucoma. It is a mydriatic and a cycloplegic that dilates the pupil, paralyzes the ciliary muscle. There is a rapid rise in the intraocular pressure due to obstruction of the aqueous humor outflow, which is already seen in case of a shallow anterior chamber and narrow angles in ACG, right? So pupillar dilatation further exacerbates it, makes it more narrow and really causes all this problem. Can you see the difference? So already the angle is narrow and further dilatation with the atropine is going to make matters worse. I hope it's clear. Okay. So another question on case of pleasuring in the same pattern. Anybody wants to attempt? We are moving to the questions. Come on quickly. Just give it a shot. Case of pleasuring seen in all patients with neurological. It's pathognomonic of this disease. Yes. Does it resolve with desferrioxamine? Yes or no? Anybody? What is desferrioxamine? It's an iron chelating agent. Seen in all patients with hepatic involvement? Yes or no? Shall I move on to the answer? So remember, take home message, not every option that is given is correct. Okay. So answer is 1 and 5. It is seen in all patients with neurological involvement and it is not pathognomonic. Kayser-Fleischer-Ring is also seen in other conditions where there is ceruloplasmin deficiency. Okay. So Wilson's disease is just one of the conditions and not pathognomonic. So it is seen in all patients with neurological features and 80% of those with hepatic involvement. And it represents a deposition of copper in Descemet's membrane around the cornea. It is not specific to Wilson's alone. Can be seen in chronic cholestatic disorders also like neonatal cholestasis. Is that clear? Desferrioxamine is a chelating agent in Wilson's disease. Penicillamine and trientine are used as chelating agents. KF ring disappears on treatment for about 3 to 5 years. But once you discontinue the treatment, it may reappear. Okay? So this is important point about KF ring. Next question. Patient presents with routine eye evaluation. You have checked his visual acuity. Snellen's chart found to be 6.6. What is the minimum angle of resolution? This is a know it or don't know it answer. Anybody knows? The answer is 5 minutes of an arc. So this is actually the angle that is subtended by an alphabet onto the fovea that is measured in degrees, right? So it is further the subdivision of degrees that is 5 minutes of an arc. Okay. So this is just a factual question. There's no concept to it, right? So one point that you should know is Snellen's chart 6.6 means what? What a normal person is able to see at 6 meters, okay, whether the patient is able to see or not. Okay. Now, if it is 660 or 636 vision, what does that mean? Anybody can unmute and say? Can anybody unmute and tell me what do you mean by 636 vision? Very simple question, but very important concept.
Like what normal person can see from 36, like the affected person can only see from 6 meters.
Fantastic, doctor. Fantastic. This clarity should be there. Okay. So what a normal person can see an object even placed at 36 meters away from his eye, this person having less vision is bound to go all the way close to it and is able to see only with 6 meters distance from his eye. Is that clear? Right? So 6.6 vision means that. So this is what I meant by 5 degrees of an arc. 5 minutes of an arc. Okay? Right. Next question. 2-year-old child. Watering of eyes with bilateral proptosis and photophobia. What may be the diagnosis? See this? Bilateral proptosis, photophobia, and watering in the eyes. What is the diagnosis? The answer is congenital glaucoma. Okay. This is a very, very classical triad. Remember this. Photophobia, lacrimation, and prominent eyeball. Okay. Photophobia, lacrimation, and prominent eyeball. So it is congenital glaucoma. And what is it called as? Anybody knows? Because the eye is looking very big, it is called as? Come on, this you would have heard. Buff-thalmos. Do you remember? Buff-thalmos. Okay. Buff-thalmos because it looks so big like the eyes of an ox. Bull, ox, right? So that is why it's called as buff-thalmos. Okay. Right. So see how this looks. Here it is unilateral, but many times it is bilateral also. Next question. I think fourth last question for the day. A patient presents to the OPD came with acute pain and watering from the eye for 3 days. There was a 3x2 mm ulcer on the cornea with rolled out margins with minimal hypopyon, most likely cause. Anybody? It's very straightforward. Pain watering 3 days, 3x2 mm, rolled out margins. What else can it be? This question is simply another way of asking viral, bacterial, fungal, or protozoal. Simple. This is what they've given one option from each. So you got to choose which one. Come on, quick. Anybody? Yes, no? Do you have an answer? Yes, no? Come on, quick. Anybody? So the moment you talk about a rolled out margin, okay, it is bound to be bacterial. That is very, very characteristic. So the description provided is indicative of corneal ulcer. The most likely cause is Pseudomonas aeruginosa. Okay, they have a very, very aggressive course. Okay, rolled out margins and minimal hypopyon. Okay, the bacterial ulcers do not have very florid hypopyon. Consistent with the bacterial corneal ulcer, it's Pseudomonas among the given options. Acanthamoeba also can cause, but remember it is very different in manifestation in the sense it starts like a small dendritic and then becomes amoeboid, geographic ulcer and like that. Okay, next question. Regarding conditions causing glaucoma, topiramate can cause bilateral angle closure, IOP decreases in pregnancy, steroids are not given in viral dendritic ulcers because they can precipitate glaucoma, and lapnoprost is contraindicated in asthma. So remember, the moment they want to ask you a lot of concepts related to a particular topic like glaucoma, they mix up everything and give it in this format and somehow achieve the target of asking an MCQ. Instead of testing you on just one concept, they'll test you on multiple, saying true, false, true, false, true, false. So the flip side or the advantage of this is we know if one or two are true or false, we can easily eliminate the other. Yes. One of the indications with is open. So that means option B is out. I decreases the increase pregnancy. Anybody knows? Okay. Steroids should not. Okay, I'll come to the easier option. Which is the drug that is contraindicated in asthma? Anybody knows? It is beta blockers. Timolol, which is used as eye drops, is contraindicated in patients with asthma. So D is false, correct? So A is true and D is false. So that leaves us with what all options? Anybody? One, that is A, B, and C, A, B, and D. Not B. A is true. So A and D are the only options left. Now, do you understand how to apply this? Okay, so between A and D, A is true and D is false. That we know. IOP, does it increase or decrease? Both of them are saying B is true. So that is out of the question. Okay, so the final answer is A is true, B is true, C is false, and D is false. Meaning IOP, it does decrease in pregnancy and steroids are not contraindicated in viral keratitis. Okay, so this is how you can narrow down the options based on one or two correct options that you know of. See, in certain cases, topical steroids may be used for viral dendritic ulcers, especially when there is a concomitant inflammatory component that needs to be addressed. Okay. And lastly, I told you this IOP reducing during pregnancy, we already knew because we ruled out the options and both of them said true. Okay. Topiramate is an anti-epileptic and anti-convulsant that is known to associate with increased risk of glaucoma, angle closure time. Next question. ETDRS chart is used for checking what? Diabetic maculopathy, near vision, distant vision, and glaucoma. Anybody? Come on, anyone? So what is the full form of ETDRS? Early treatment of diabetic retinopathy study. Okay, so we know that it is somehow related to diabetes. But remember, it is for visual acuity in diabetes. Okay, so the answer is actually distance vision. It is not for diabetic maculopathy only. Okay, it is provided a standardized and precise measurement for measuring visual acuity. Consists of letters or autotypes arranged in rows, with each row containing letters of decreasing size. Okay, so it looks like this. Remember, in Snellens, they do not have equal number of alphabets. Here, from the first row till the last row, the number of alphabets is equal and they're equally proportionally spaced. This helps us overcome a lot of disadvantages associated with Snellens. Okay, let's not get into the details of that, but this is useful in patients with, not just with diabetic maculopathy, but in diabetics in general. Okay, next, second last question of the day. Which of the following is not a feature of complicated cataracts? Come on, this everybody knows. Without this, nobody could have crossed our undergraduation, because this is, so hyped up and overrated among teachers to not miss out during classes. So tell me. Anybody? Unmute yourself. Anybody? Breadcrumb appearance and polychromatic luster are things we keep mumbling even in our sleep during our post-graduation days. So these things cannot be missed. Of course, it is occurring after uveitis. So the odd one out here is Krukenberg spindle, which is seen as a part of pigmentary glaucoma. It is not a feature of complicated cataract. Is it clear? So it is a type of cataract secondary to other ocular conditions, often uveitis. Okay. It refers to the vertical deposition of pigmented material on the posterior surface of the cornea central endothelium, commonly associated with pigment dispersion syndrome and pigmentary glaucoma rather than cataracts. Clear? So it is not a feature of complicated cataracts. Can you see this Krukenberg spindle picture here? So this is how it looks. So this is deposited on the cornea, but on the back side of the cornea. Last question. What is the moment to simple? Again, asking you this question. Okay. Put your order on for the thing. Yeah, this is the last. So diabetic patient with the following finding on angiography and has gradual progressive vision loss. What is the cause of this finding? What is this test again? This one of you has to unmute and tell me, because that's how we started the class. So I want to know if you have been alert. What test is this?
Fundus fluorescein angiography.
Superb, superb. So this is fundus fluorescein angiography. Remember, whenever there is hemorrhage, we won't be seeing anything beyond the hemorrhage. So here we are not seeing any hemorrhage, right? So here it is actually ischemic retinopathy. Why is it ischemic retinopathy? Because can you see that instead of just the central part being dark, can you see the grayish extension over the rest of the parts also? So the entire retina is now becoming ischemic because of poor blood supply. Okay, these are end arteries, they tend to get blocked and having poor blood supply. So it is diabetic ischemic retinopathy. So what are the various findings? Microaneurysms, retinal hemorrhages, okay, cottonwool spots. And in later stages, because of this ischemia persisting for long, they can develop new vessels in an effort to try to supply blood and oxygen, and those vessels are often very weak, tend to bleed, and that can result in hemorrhage and retinal detachment also. Is that clear? So these are certain manifestations of diabetic retinopathy, early and late, and their consequent complications. Clear? So these are some important topics that I wanted to cover in the short span of 2 hours. And I wanted to keep the last 10 minutes of today for question answer session and doubts clearing if you have any. So I will, now I think it's 8:45. So I'll leave it to you people to ask me any questions or any clarifications so that we can try to solve them as much as possible before we wind up for the day. Come on. Anybody has any doubts, questions? No? All topics clear. How did you find this class? See, it's humanly impossible to cover the entire ophthalmology in 2 hours, but I tried to pick up questions from topics which are least covered, right? And these are not completely out of way because these have appeared in the previous year paper. So they are very much within, of course, syllabus is entire ophthalmology, but these are very much within the purview of entrance exam perspective as well. So before we move on to the feedback, any doubts, any queries anybody has that you want to ask? Anybody here who's still doing their, maybe pre-final or final? Or all of them are interns and post-interns? If you don't have any doubts, at least you can come forward and share your feedback as to did you like the class? Do you feel it was a little bit overwhelming? Did you find it useful? Just feel free to share your views on this so that we can always make the next class more suitable and better for you all. Anybody? Dr. Meghna, Dr. Beena, Dr. Libin, Dr. Rohan, Dr. Junaid. Anybody wants to share anything? If there are no doubts, any queries or anything, I think, Bijon sir, can we wind up for the day? I think it's 8:50.
Yeah. Okay. And probably they have subscribed for the Medico app. They will be covering the other topics which I'm covered. Okay. So you're a class only, in the Medico app.
Yes, yes.
So ophthalmology part they will be covering.
Super.
So, okay. Thank you. I'll
Okay.
call you later by tomorrow day after. Okay.
Okay, sir. Okay. Thank you all. Thank you for attending and wish you all the very best for the upcoming exam. And I'm sure you'll all do fantastically and come out in flying colors. Once again, wish you all the very best. And please feel free to contact us in case you have any doubts, queries. And also do subscribe to the Medico app if you haven't, where we'll be covering the rest of the topics as well. And once again, thank you and have a good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Aishwarya can wind up the meeting. പായസം കഴിഞ്ഞാ ഇതേടോ ഫോട്ടോസ് മതി ജിലേബി എടുത്തോന്നാ കുറച്ച് ജിലേബി അല്ലേ ഞാൻ വാങ്ങിച്ച ജിലേബി അല്ലേ
ഡാഡി മനസ്സിലായി. ഡാഡി സ്റ്റാൻഡ്